Hello and welcome to the Business Talk podcast. I'm your host Deepak. It is my great pleasure to welcome Dr. Aneri Shah Ambani, a distinguished Vitreo-Retina surgeon with exceptional clinical, surgical, and academic expertise as our esteemed guest on today's episode. Dr. Aneri is currently practicing at Core Vision Eye Clinic, Ahmedabad, and also serves at the Center for Sight and GMERS Medical College. She has previously worked as Vitreo-Retina and Uveitis specialist at Tej Eye Centre, Gandhinagar. A gold medalist in MS Ophthalmology from Gujarat University, Dr. Shah has trained at premier institutes including LV Prasad Eye Institute, Hyderabad, Sankara Eye Hospital, Bangalore, and internationally at Massachusetts Eye and Ear and Harvard University. She has performed over 200 vitreo-retinal surgeries and 1,000 ophthalmic surgeries independently, with special expertise in pediatric retina disease like ROP, FEVR, and Coats disease, uveitis management, diabetic retinopathy, and complex retinal detachments. An accomplished academic, she has several peer-reviewed publications and has presented her work at national and international forums like American Society of Retina Specialists and Turkey Ophthalmic Society. She is a recipient of the prestigious Nugent Grant for Research in Keratoconus Diagnosis and is a fellow of the International Council of Ophthalmology UK. A life member of various organizations, Dr. Shah remains actively engaged in advancing her field through research, presentations, and continuing medical education. In this episode, Dr. Aneri Shah Ambani shares valuable insights from her medical research, diabetes and preventable blindness, early detection, intervention, and awareness, highlighting the critical role of early diagnosis and public awareness in preventing vision loss. So, kicking off this exciting conversation, let's warmly welcome Dr. Aneri Shah Ambani to the show. It's a real privilege to welcome you, Dr. Aneri. Thank you for joining us.
Thank you so much, Mr. Deepak. Good morning, everyone. And I am so glad and excited to be here on Business Talks. I am excited to share some insights about diabetic retinopathy and health preventable blindness. Thank you.
Yeah. Dr. Aneri, to begin with, can you explain what diabetic retinopathy is and why diabetes poses such a significant threat to vision?
Yes, definitely. Before starting with diabetes, I would just like for you all to know a basic anatomy of eyeball. So this is a model of eyeball we generally see from front. So this is the cornea, that is the transparent layer of eyeball. Behind the cornea, the colored part is the iris, that is brown or black in Indian population. Behind that, there is the lens, where we call it cataract generates. It gets whitened and then we remove it and put a transparent intraocular lens. This is the vitreous jelly which forms the eyeball. It is the jelly-like structures which maintain the integrity, and the behind posterior most part, the yellow part, is retina. Retina is made of neural fiber layers which gets accumulated at the posterior part, and this is called optic nerve, which goes into the brain and we see a picture. So retina is like a film. If we take eyeball as a camera, it captures the image and then it is displayed over the film. It is processed over in the film in the retina, and then our brain sees it. Diabetes basically affects this retina structure. Retina has blood vessels. Because of constant hyperglycemia, because of continuous high glucose in our body, blood vessels internal structure, the endothelium, gets affected and becomes leaky. So blood vessels leak protein, lipid, fluid over the retina. It gets accumulated over to the retina, which we call diabetic retinopathy, and hampers our vision. Right. It is basically that. The pathophysiology is two. There is a non-proliferative diabetic retinopathy and proliferative diabetic retinopathy. In non-proliferation, these vessels become leaky and edema starts to form, fluid leakage and edema occurs, which hampers our central vision, which we call macular edema, and patients generally experience central blurring of vision. In proliferative diabetic retinopathy, which is more severe stage of diabetic retinopathy, generally what happens is these blood vessels gets clogged or obliterated, occluded, and retina does not get enough blood supply. Blood supply also contains oxygen. So retina does not get enough oxygen also. So body tries to compensate that by making abnormal new vessels. These vessels, as they are abnormal, are more prone to leakage, more prone to rupture, and very minute stress also causes bleeding due to rupture of these blood vessels, which we call vitreous hemorrhage, is a more severe kind of retinopathy. And these vessels contract into the vitreous, into the jelly-like structure of the eyeball, causes traction over to the retina, which we call tractional retinal detachment, and so.
Very insightful. Doctor, in your clinical experience, are you seeing a rise in diabetic eye disease in India, particularly among younger patients?
Definitely. You will be surprised to know that there are over 77 million people in India suffering from diabetes. Amongst these, at least 18 to 20% people develop diabetic retinopathy. So these are the people who develop any form of any grade of retinopathy. Amongst this, at least 5% people develop visually threatening diabetic retinopathy, which we call with development of proliferative diabetic retinopathy, the more severe stages. So that is that, which was 2% 20 years ago. So that is the vast rise. Apart from this, younger population is getting more affected with diabetes. Diabetic retinopathy development, the most common risk factor for that is the age, the duration of diabetes. Say if you have 10 to 15 years of diabetes, after 15 years, development of retinopathy chances are more than 70 to 75%. So the more younger age you develop diabetes, there is more likely chance of developing retinopathy and getting your vision affected.
How crucial is early screening in preventing blindness caused by diabetes? And when should a diabetic patient ideally have their first eye exam?
Screening is of utmost importance because we generally say diabetic retinopathy is a silent killer of eye. You do not get to know if you have diabetic retinopathy or not because not necessarily if your vision is normal, your retina is. So you might be having retinopathy without any symptoms of vision or symptoms of eye. Generally, for type 1 diabetic patients, we recommend first screening after 5 years of diabetes. And for type 2 diabetes, we generally recommend at the time of diagnosis, get your retina checked because we don't know since how long they were part of diabetes mellitus. So at the time of diagnosis, it is of utmost importance that you get your retina checked. After that, if it is normal, yearly checkups are fine. If it is abnormal, if you are having early diabetic retinopathy, then you'll be required to undergo screening every 6 months or less interval if more severe and so on. But it is more crucial because early stages of retinopathy are generally reversible. We don't need any ocular treatment for reversal of early stages. You can just maintain your lifestyle, maintain your weight, hemoglobin, your diabetes. Sugar spikes are the most hamperful. So avoid sugar spikes at all costs. You can maintain your BP and so on, some lifestyle modification, and you can get your diabetic retinopathy reversed. Another important thing is HbA1c. We generally, data suggests that even 1% drop in HbA1c causes 30 to 35% drop in chances of development of diabetic retinopathy. So HbA1c is one of the most crucial factors that you can, from which you can get a basic idea about retinopathy.
Dr. Aneri, could you walk us through the early sign of diabetic retinopathy that patients and even doctors should not miss?
Yeah. Diabetic patients generally, because of diabetes, apart from retinopathy, some common symptoms are frequent change in refraction. So people often experience that they are not satisfied with glasses. They often feel that their glasses number keeps on changing. That is because of diabetes. Another is frequent infections of eyelid, like sty and everything, which is more common because of high sugar level. Apart from that, blurring of vision is there. The central part of blurring, which is caused by macular edema, people often experience that. If someone has higher grade of retinopathy, sudden loss of vision because of rupture of abnormal blood vessel, neovascular vessel, and causing vitreous hemorrhage, they often experience overnight blurring or loss of vision. It can be due to tractional retinal detachment as well. So these are some symptoms that patients experience during retinopathy development. For clinicians, for ophthalmologists, everyone knows that microaneurysms are the first sign to develop. And generally, you can get to any ophthalmologist or retina specialist and get a dilated retina checkup done. It takes hardly 20 to 30 minutes to dilate your pupils and do indirect ophthalmoscopy or fundus examination, basically. And you can get the idea if you have diabetic retinopathy or not.
How has the technology advanced in the early detection and management of diabetic retinopathy? For example, innovations like OCT, AI-based screening, or laser therapies.
Yeah, actually for retinopathy, as I said, we generally do fundus examination, dilated fundus examination foremost. And if there are any positive signs of retinopathy, like microaneurysms or dot blot hemorrhages, there are some hemorrhage-like things, red dots over the retina, or it can be lipid accumulation, cholesterol accumulation. There are OCT. OCT is basically a CT scan kind of a thing for retina. It gives you a cross-sectional idea, mainly for macular edema. So these blood vessels, when they get fragile, they leak fluid and it gets accumulated in the central part of retina, which is called macula. It causes the main visual disturbance. The edema is generally investigated by OCT, and on OCT, how the edema is, we generally go forward with the treatment. Like if we want to go for intravitreal injections or some other type of implants for diabetic retinopathy or some other thing. There are very basic, very nice innovations like OCT angiography, fundus fluorescent angiography, OCT angiography, and laser therapy and anti-VEGF therapy to control diabetic retinopathy in non-proliferative form so that it does not go on to progression to proliferative stage. So if we see any of the signs like macular edema or something, we generally treat it with anti-VEGF injections or Ozurdex or steroid implants, basically. And if there is no edema in the central part, but if we see early proliferation, early neovascular or abnormal vessels, which can cause further vision loss, we generally treat it with laser. So with laser, what we do is we decrease the metabolic need of retina. There is less oxygen in the peripheral part of retina, which is causing the body to develop abnormal vessels. So we treat over to that part of retina to conserve the central good part of retina. So with laser, there are generally 2 or 3 sittings of laser done. And we decrease the metabolic need. We convert the retina from hypoxic stage to anoxic state so that retina, the central good retina, can get more oxygen and the chances of progression falls.
When it comes to treatment options today, how do you approach managing early stage versus advanced diabetic retinopathy?
Yeah, so that is what we talked about. For early stages, the generally earliest stages can be managed conservatively by patients only. There are some factors you can keep into check and you can get the diabetic retinopathy reversed, like HbA1c. You can get check of your weight, BP, the overall diabetic control. I will again say that you can keep your sugar from 100 to 200 and avoid spikes, even low spikes and high spikes. So you can take frequent diet, but short quantity every 2 hourly and get your sugar in check. Apart from that, renal function is very important. How well your kidney works, that is very much important for retina also in diabetes, and you can get early reversed. For moderate diabetic retinopathy, we have some measures for macular edema and some vision-threatening retinopathy like anti-VEGF injections. And for more so, we have laser therapies to reverse it or control it. For very highly developed diabetic retinopathy, like for vitreous hemorrhage and for fractional retinal detachments and more progressive retinopathies, we have to then ultimate measure is to undergo surgery. Surgery nowadays has become very much advanced. The machines are very much advanced. So it is a sutureless vitrectomy procedure. In this procedure, we go through into the eye from sclera and we remove the jelly part, which is called vitrectomy. If vitreous hemorrhage is there, the blood is generally accumulated in this part. And then we treat retina as in what is required. We do laser. If there are abnormal membranes, we peel it. And then retina is settled with air or gas, or if in very advanced stage, oil. But generally, it is after surgery, patients do require to take rest for 15 days, but there are no sutures or any kind of thing. And if is treated early, then prognosis is good.
Dr. Aneri, a lot of patients are afraid of injections and surgery for their eyes. Could you shed some light on the modern treatments like intravitreal injections and why timely intervention is key?
Yeah. For intravitreal injections are mainly to treat macular edema. Edema occurs because retina, when develops retinopathy and leakage occurs, there is a factor called VEGF, vascular endothelial growth factor, which gets released, which increases the permeability of blood vessels and edema accumulates. So from these injections are basically various drugs of anti-VEGF agents. They inhibit the VEGF release from the retina and absorbs the fluid. So these injections are considered a outpatient procedure. We put some drops, topical anesthesia to anesthetize the patient. These drops are put 5 minutes before giving the injection, and the injection process hardly takes about 2 to 3 minutes. You don't require to take any precautional measures pre or post injections. In most of the cases, we do see the patient on the next day to avoid any reaction or anything and to know about that. But other than that, it is considered comparatively safe procedure than better than surgery, of course. Surgery right now, because we have such good machines, it is sutureless. So that is the most advantageous part. We have micro techniques and micro therapeutics for that. So it is done under local anesthesia. We generally give injection over here and here to anesthetize the eye, and surgical parts take about 1 to 1.5 hours for the retinopathy. If retinopathy is caught early, anti-VEGF injections and lasers generally take care of most of the cases. Surgical cases, if it is in very late stages or for type 1 diabetics, generally it is more commonly done.
Beyond clinical care, what community initiatives do you think are the most effective for raising awareness about diabetic-related blindness?
For community, I think telescreening is the most important thing. Now at diabetologist also fundus camera is available. There are various modulatory fundus camera which can be mobile, and we can there are camps and everything where mobile one is there and there is a fundus camera and you can click the photo and then send it to the retina surgeon over the phone or some software or something, and someone can analyze them. If you see any positive findings, then that patient is referred to the hospital. Otherwise, this is a good screening measure where people don't have to come to the hospital and they get diagnosed, basically. So telescreening is very widely available, and that is one of the foremost tools, which is good. Apart from that, diabetologists and general physicians and practitioners should keep in mind that just, get your patient retina checkup done at least once in a year. If that you can just add that to your questionnaire and get that done, basically.
Dr. Aneri, how can primary care physicians, diabetologists, and even general practitioners play a bigger role in early detection and referral process?
Yeah, so as I said, you can just diabetologists, general physicians, and practitioners are going to treat and see diabetes basically. So they can just they do that, but they just add that to your questionnaire as they get HbA1c done or RBS monitoring done or kidney profile done. They can ask the patient if they have had retina checkup done or not. And if not, at least once in a year is advisable. For type 1, as we discussed, 5 years post-diagnosis of type 1 diabetes mellitus, retina checkup is essential. And for type 2, which is 90% of the diabetes, at the time of diagnosis, it is needed. After that, yearly checkups are also that much crucial. I have seen patients, they've gotten retina checkup done once in their life, and then retina was normal and they don't follow up. So follow up is also that much important, because diabetes, how much duration you've had diabetes plays a role in development of retinopathy. So that is also very crucial that you follow up with ophthalmologist or retina surgeon at least once a year.
Lastly, what message would you like to share with our listeners, especially those living with diabetes, about protecting their vision for the long term?
Yeah, so eyes are a windows to the world. So we do want to maintain them. For diabetic retinopathy, you just have to go for a routine checkup once a year, once in 6 months, and get your retina checked. And that will take care of most parts. As we say, prevention is better than cure. So early detection of diabetes is very much important, because we are in reversible stage, in early stages. So we can easily revert it by other means. That is the most important. You follow up with your doctor, you take regular appointments and do follow up, right?
Listeners, as we come to the close to this enriching episode, I would like to sincerely thank Dr. Aneri Shah Ambani for joining us and sharing her invaluable expertise. Her deep knowledge and vast clinical experience and commitment to advancing ophthalmology, especially in the areas of diabetic eye disease and preventable blindness, have truly been inspiring. Dr. Shah's insights into early detection, intervention, and awareness have highlighted not just the scientific advancement, but also the human impact of timely eye care. Her dedication to research, education, and patient care stands as a beacon for aspiring ophthalmologists and healthcare professionals everywhere. Audience, thank you for tuning in. Stay connected, stay informed, and until next time, take care of your vision and your health. Thank you once again, Dr. Aneri Shah Ambani, for enlightening and motivating conversation.
Thank you so much, Mr. Deepak, for giving me the opportunity and the platform to talk to the people. Thank
Thank
you.
you. Thank you.